Hello and welcome everyone for tonight's EAO Just Ask. Tonight, it's the last Just Ask of this year's. Christmas is coming, and I would say we have a highlight for you today. We have a true clinical and scientific expert. We have a friend here. We have another German here. He is in charge of the prestigious Department of Periodontology of the University of Gothenburg, where all these big names were, Linde, Berglund, Wenström. And Jan, I had the chance to teach you a little bit of suturing nearly 20 years ago. Today, it's your chance to teach me how to treat peri-implantitis. With this, I want to welcome you on behalf of the EAO for tonight's EAO Just Ask, Jan Derks. It's a pleasure to host you.
Thanks, Stefan. The pleasure is mine. It's, it's on me to say thanks for having me, also to the EAO, and I hope I can repay you for teaching me how to suture 20 years ago.
You will definitely do that. Jan, we already have a lot of people logging in from all around the world. I mean, I know you travel the world for all your lectures and consensus conferences. We have people from Uganda, from Saudi Arabia, from Albania. We have people from Serbia, from England, so all around the globe. They want to hear your knowledge. And Jan, I did a case today. And I thought about you. I had you in my back of my mind. I knew I have a top-notch expert here tonight. And I had a peri-implantitis this morning. I flapped it open, and as you see it, I did an infracrestal treatment with a tie brush. I did a little bit of an implantoplasty in the supracrestal area. I grafted the infracrestal component, and I closed everything. And I had you in the back of my mind a little bit. I think you were whispering, don't do an implantoplasty, Stefan. But come on, Jan, what's your take? Would you do the same? Would you do it different? And is it good for me to hear your lecture today?
Well, I'm pretty sure I can share some valuable insights with you. Some of the aspects that you just mentioned, we would do exactly the same. But you're also correct and you'll hear that in a minute, I'll argue that we shouldn't do implantoplasty. So in that aspect, I'm pretty black and white. Then on the aspect of using the titanium brush, the rotating brush, completely agree with your approach. And then also the reconstructive approach you chose here in the upper anterior, I would also agree that. So two aspects, yes. But on the implantoplasty, I would say no.
So we could say I am on my way. I'm 75% correct, and the rest I'm going to learn today. Can we put it like this?
I think that's a fair assessment.
Jan, it's great to have you. You prepared a little bit of content. We have, again, more and more people logging in. We have Mario Romandini. Hi, Mario. We have a lot of other people. So we want to hear your content. And it's a little bit the tradition of this Just Ask, because the name of this format is Just Ask. So I will allow me to interrupt at any time to discuss things with you, to deepen things maybe, to hand over questions maybe from the audience to you, if this is fine for you. With this, I would love to hear your content. Yeah.
Perfect. Let me also just tag on to what you said and encourage everybody to step in, to send your questions. And Stefan, you will put them to me and I'll be happy to discuss. I prepared roughly 15 minutes or so, and obviously share with you briefly the concept on how we treat peri-implantitis.
Perfect.
Just a small personal comment. Let me also say hey to Mario Romandini that you just mentioned, also logged in. So having said that, I want to say thanks to the EAO once more and share with you our treatment approach on cases such as these, right? The typical signs of peri-implantitis. To get one message across, we have to probe, right? That's part of the diagnosis, and you can see the deepened probing here to your lower right, and the typical signs associated with the disease, that is the kind of angular defects, the crater-like or bony defects. I'll share with you in a second on how we deal, how we structure the treatment, but many of these cases, if not most of them, will end up in a surgical approach. So I'll obviously focus on these aspects. And then when we follow up these cases, I'll share with you the radiographic follow-up roughly 5 years down the road. And we all like these image before and after, but I will argue that the key outcome, the determinant of success or failure, is not the radiograph that you see here. It's the clinical outcome indicated by shallow probing, absence of inflammation, signs of inflammation, and that will determine the long outcome, the long-term outcome of this case. Let me just also mention a document that I'll lean on, also speaking towards Stefan's comment on how we should clean, implantoplasty and the like. This is a reference that I think you should take a look at, guidelines from the EFP on how to manage peri-implant diseases. And they say one thing. When we approach these cases, you should look at them basically as you would at a periodontitis case, meaning that the very first step of what you should do is inform the patient and establish proper supramarginal plaque control. So if I put it simple, teach the patient how to clean. And on top of that, you should perform a non-surgical treatment. You want to evaluate what happens. It's not necessary maybe to wait months as we would do with perio, but give it a couple of weeks, see if you can resolve the situation. You will rarely resolve it, but you give the patient a chance to demonstrate that he or she can clean, and then you'll move into the surgical approach. So you never jump into surgery from the beginning. You'll do that in a second stage, right? So that message is quite clear. And what you're looking at, either by non-surgical or the surgical treatment, is to get rid of the pocket.
Jan, can I cling in here for
Please.
a quick second? You say we have to teach the patient how to do cleaning. Sometimes it's difficult to clean this critical structure with overhanging margins, maybe with blocked margins and blocked crowns. What would you recommend in these cases? Should we redo the reconstruction, or what is the approach when we see the patient is not able to clean it?
Yeah, I mean to put it pretty straight, a straight answer is, we'll either have to adapt the superconstruction and in some cases redo it. And actually what you're saying, Stefan, that will be part of what you see in green here, your initial approach to the treatment, because nothing will work down the road if we ignore this problem. And I mean, let's be pragmatic. I mean, that could be quite painful, right? Because if it's your own work, either way, there will be costs that have to be, conveyed to the patient. So admittedly, this is a difficult step, but completely necessary, right?
Get it.
And should be done early in this structured approach, right?
Get it.
So what you're looking for is the resolution of the inflammation, right? And the EFP stipulates that a 5 millimeter probing and limited bleeding would be what we're going for. Again, rarely this will be achieved by non-surgical, so it's typically a surgical case, right? But let me just show you very briefly how we do the non-surgical treatment. And the images here now have to be very clear. What you should do is indicated on the left, dedicated tips, ultrasonic instruments. What you shouldn't do, and I'll go into more detail, is what you see on the right. Right? The air abrasive is something that you should be careful with. It's a very elegant instrument. There's no problem in that way, but you should be a little bit careful. To be more specific, I have a video of what we do. So once again, it's a dedicated ultrasonic tip, quite slim and elegant, to also here reach the pocket. And you can see the calculus that is kind of jumping out of the pocket, right? So that's our green treatment phase, if you want. If I bring up the document that I mentioned earlier.
This is a regular steel ultrasonic tip?
Thanks for asking. No, actually, no. It's a dedicated implant tip, not the metal one that you would use at teeth. This is a combination, and there are, many different manufacturers, but this is a combination of a PMMA
Yeah,
and some graphite. So
yeah.
it's a 80-20 combination, as far as I know, 70-30. I may be wrong on the percentages, but these are meant for metal surfaces, right?
Are
The
you afraid
idea.
of any remnants which are just getting off during the process?
Yeah, that's a concern, which has been shown in preclinical trials to be a problem. So that is something that want to avoid, maybe the overly aggressive
But
instrumentation.
you're opening it anyway, right? So,
In many of these cases, either
yeah.
way, exactly. The alternative, so to say, is to using the metal
Mm.
scalar steel that we know will damage the surface
Uh,
critically, right? So that is something that should be avoided.
yeah.
So from a guideline point of view, the submarginal instrumentation is recommended using either what you just saw, a dedicated tip, or hand instruments, right? And they will, of course, be very difficult to apply in a threaded device. If I turn it around now, what you shouldn't do, and I already highlighted that or mentioned that, with a kind of careful suggest not to, would be a laser, the air polishing, photodynamic devices. And the problem is that they may not be directly harmful. The problem is that they are either expensive,
Mm.
so the cost benefit is not, favorable, and actually the air abrasive may be harmful because we run the risk for emphysema, right? So given that there has been no benefit demonstrated as of now, these are the recommendations that the EFP is giving. And I think as a young dentist, maybe in your own office, running against these recommendations, running risks is probably not something that you should do. So we use the ultrasonic, and then we go pretty fast into the decision making, meaning that if we don't immediately achieve the resolution, we go into surgery. The only question really is the patient compliant? So it would be the dental hygienist to tell me, no, we should wait a little more. Otherwise, we are into surgery 6 weeks, 8 weeks. So it's a shorter period, right? And let me show you a little bit how we do. The procedure is actually rather simple, if I may say so. Whenever possible, we take off the superconstruction for the surgery. And that may depend. If it's possible, makes surgery a lot easier. The case that I'm running now, these were cemented crowns, so they'll obviously be in place. Now, incisions are sulcal incisions. You go in as deep as you can into proximal, and then you'll find intact bone lateral to the defect. I am here now anterior to the defect, and you will raise a full thickness flap, passing the most apical part of the defect. So you'll be somewhere up here, right? After that, you will be able to bluntly dissect the inflammatory lesion from the flap, meaning that you will have a clean flap and the inflammation remains in the defect like a scarf around the implant. And this lesion, you identify it here in situ while you have a clean flap raised. And this you can't do in perio, right? In perio, you need a knife. But in peri-implantitis, you can do that bluntly, as you saw with my elevator. And then you can quite easily remove this bag of inflammatory tissue basically in one piece. You could sometimes even use the suction to get it out. Again, in perio, you will need to instrument debride quite a lot. And this will be very easy. And then you have a site that will not bleed, and you can actually start the decontamination process, right? So my next question is, how should we clean? And I would suggest that you start with a metal scaler. I have titanium coated, but on this one, I would not be overly hard black and white. If you have a regular steel scaler, in my mind, that's fine. But the work that you do is horizontal, right? I mean, you kind of chip along the threads. It's not a vertical work that you perform.
Does that account only for hard deposit now?
Yeah.
Yeah,
The point here being that
this calculus.
exactly, right? You
Yeah,
see the brushes up here, the single tufted brush. You'll see that in the video in a second, but actually that's what I do first, and I kind of get an overview of what I have.
yeah,
In some cases there's no calculus.
yeah.
In others there may be quite a bit, and obviously that is the target of your horizontal scaling. And then once you're done, the central instrument for us is what you see here, and I think you mentioned it, Stefan. Also, it's this rotating titanium brush, I should say. Again, many different versions on the market. The one we use has this long shaft, and the bristles point forward almost like you paint, right? So it looks a little bit like this. You get an overview with this single tufted, and then I go quite slow. I think the manufacturer says 1200 RPMs, and actually I think I'm lower than that.
Mm.
And the irrigation that you see here is saline only, right? That's it. And it's quite elegant. You'll get everywhere, also into the angular defects. And I actually don't hesitate also to touch a little bit the bone. I mean,
Yeah.
it's not like this is an overly careful procedure. And the
Do you,
feeling,
Jan, do you always do it clockwise or also do it sometimes
yeah,
anti-clockwise?
no, I just do the best I can to get everywhere. So it's not like I would have a certain direction. I would go, you know, either
No,
way.
I'm talking about the rotation.
Oh, I'm sorry. No, I misunderstood you, Stefan. No. I only go the regular one. Sorry,
Okay.
I would not reverse the handpiece. I misunderstood you.
Yeah,
Sorry.
yeah, yeah. Okay, got it.
No. It's I just go the one direction,
Yeah.
and what you see here on this image is what you get, like a, let's say, clinically satisfying, shiny surface. But we also know that we do. I mean, damage is maybe the wrong word, but we do influence the surface by there are some scratches, and you're probably rounding off the threads a little bit, right? But it's not the point of the procedure. It's rather, so to say, a side effect if you want, right? Now,
But can we stick to that point a little bit because I think it's
please.
very interesting. You say you change the surface a little bit, but Jan, don't we want that a little bit? Don't we want to get rid of this moderately rough surface at least a little bit?
Well, you're correct in that conceptually I would completely agree, right? If I could end up with a smoother surface,
Sort of machined one?
I'd be more than happy. But if we are, let's say, a little bit realistic, you are in a surgical site with everything that entails. This idea of creating a smooth surface by titanium brush, and we'll move into implantoplasty. I mean, that to me is a hypothetical idea. You will, at least in some regions, fail, right? So you will maybe even go into the other direction and create a rougher surface by, cutting maybe into the metal or whatever it is.
So do
So
you think it's a myth that some people say with the tie brush you are changing the implant from a moderately rough surface to a machined surface? Is
yeah,
that a myth?
I would argue yes, right? You may here and there be able to do so, but not consistently and not
Yeah.
circumferentially. So I would never claim that I am creating a more favorable surface, but that's fine.
Okay.
My target is to create a clean surface, right?
Yeah.
And that would be the, so to say, and I'll show it to you in a minute. We are consistently able to do so. And
Okay.
I lean on the results that we can achieve.
Yeah. Get it.
But I would not argue that we creating this favorable surface that
Okay.
that we connect to old machined implants that
Yeah.
we had once in a time. Yeah. But you mentioned implantoplasty, right? And you and I were maybe not in agreement conceptually. And let's look at the EFP and take this as a starting point for the discussion, right?
Yeah.
What do they say? And now we're talking surgical cleaning, right? And they would say again, don't use the air abrasive, which makes sense because the system's not sterile, right? So to apply it in a surgical setting is not, so to say, is not okay in that sense. It's not like titanium brushes get this high recommendation, right? They are a little bit like, okay, they are fine, you could consider them, but it's not like we have this huge bulk of evidence behind what I've been showing you. I have to admit that. And when it comes to implantoplasty, they say actually we can't say anything. And now you have to think about this is 23, right? So things have happened since then. But think about it for a second. You are on purpose changing, damaging the implant, right? On purpose. It's not like a side effect. Is you're saying from the get-go, I'm gonna, cut away whatever threads there are. You don't have any evidence, trial evidence, that shows you a benefit, but you have a defined harm. So the cost benefit, as of now, is on the negative side. So that already tells you the recommendations have to be negative, right? We basically shouldn't do it. And now, since this 23, there have been studies coming out, and I've been part of one, comparing what you and I are talking about now, right? Let's say we compare implantoplasty to what we now consider to be standard of care, the titanium brush, right? In a trial, we compare these two, and this is my colleague, Professor Cha from Seoul, who operated these patients. And you will recognize the brush more or less, right? And then what you've been doing also here, changing the implant, removing the threads. Now, I don't want to go into much detail, but the story is this. Across all variables, the implantoplasty is not doing better, right? However, when it comes to the radiograph at 1 year, you will have additional bone loss, while in the titanium brush, it's stable, right?
You
So
think
it's
it's
not
because
only
of heating maybe?
right. I could speculate the heat. I could speculate about particles. I could, but for sure, these are potentially dangerous aspects. So the evidence is not only saying it's not better, it's actually going the other way around. So my personal take out of this is, if you're asking me for a recommendation, don't do the implantoplasty. The titanium brush, as of now, is probably what we should go for.
I mean, Jan, my feeling a little bit, just to tell you why I do it, I obviously also know your studies and of course the consensus recommendations. My feeling is a little bit, but that's just a clinical feeling, is it is very difficult for me to leave sort of a surface which will never enter into bone again, like a supracrestal thread. For me, it makes sense when it comes to maybe relapse to remove these areas. But this is just a clinical feeling. We have no data on that, right? Sort of making the area where I know there will never be bone, try to make it like more in a transmucosal component. But this is at least my feeling, but we have no data on that, right?
No, I could completely follow your hypothesis, right? I mean, it makes sense. It will be easier for the patient in a day-to-day situation, easier for the professional to clean during maintenance care. But the problem is, as you say, right, we are running some risks. And if we don't have, so to say, the data to push us into this direction, we probably can't do it. And now I'm not saying I never did it, so to say. It's not like that, but it's something that, do you build this into your concept? Basically, you do it on a regular basis. And in my head, that's something we can advocate, right?
Get your point.
But don't misunderstand me. If there is a study coming out tomorrow, the data will change, then we'll have to react, right?
Then we have to redo the just ask.
Right? Then we'll meet again in a couple of months or so, and I'll change my mind. I'll be happy to.
Okay.
Stefan,
Jan, there's a question from Mauro, which actually fits nicely into that. He obviously saw that this is a thionite surface which you worked on in the video. Are you able to sort? I mean, and you know how the thionite surface looks. Are you able to sort of instrumentate also these craters? So can we also be sure in these kind of surfaces that the Thai brush works?
No, I mean, I can't be sure. That's my direct answer, of course. And I could go back to preclinical studies that you also have done, Stefan, experimental models and so that show us that certain surfaces are more difficult to clean and so on, so on. And this has also been shown in clinical data, right? If I turn to my own clinical experience, is that I would say the surface that has been mentioned now is probably more difficult to clean. I can't be sure, but I can show you a whole series of cases where we also are able to treat successfully surfaces that are classified as difficult to treat. So I would put it like this. You have the surface you have to deal with it, right? It's too late to change that surface. And the titanium brush, in my personal experience, gives you a chance to do so, right?
Got it.
But promise, and again, are you able to change the surface and so on? I wouldn't go there.
I got it.
Stefan, my last question that I would like to address, and I think it also fits with your case, is what should we do with the defect, right? Actually, the case that you're seeing here is the one I showed you before, and that's also the surface that we just touched on. Now, the standard of care, let's say the basic approach would be open, clean, and close. The one that you see to the left, right? This means the fastest, the cheapest. If we now add something that is a graft, a membrane maybe, and that's what you did, we would have to ask more of the treatment, right? We would have to have some kind of benefit because the costs are there.
Right.
The question is, where are the benefits? And we did a study a couple of years ago, and you can see a whole bunch of colleagues that were involved across Europe asking exactly this question. And we limited ourselves to the graft alone, right? So the membrane, let's save that. I'm sure we can discuss. But we compared the two that you just saw on the images. And what we found is, a little bit counterintuitive because when it comes to what I said is the first, so to say, target, getting rid of the pocket, right? It turns out that actually you are equally good in both. So if you're asking the patient to, I don't know, pay another 150 euros, 200 euros, it can't be because you argue that the case will heal better. And the data is consistent. This study and basically all studies show the same thing. You'll have good healing, but it won't be better by putting a graft, a membrane, or whatever it is. The data show, however, that there is a benefit in what we would consider typically to be a secondary outcome. And this could be an aesthetic outcome, meaning that you could limit soft tissue recession. Not prevent it, I mean, that's not possible, but you could limit it. And our magnitude of benefit was 0.4, 0.5 millimeters, right? I mean, not that much, but significant from a statistical point of view. My conclusion out of this data, I reflect in two quick cases, and then I'll close my section. If now healing will be the same, but aesthetics will be different, the question whether I will put something into the defect or not is driven by the aesthetics. That may or may not be a question, right? If you look at this case, an upper molar, aesthetics are out of the table. And this case actually also speaks to your comment, Stefan, that you just made of exposed threads in a supracrestal area, right? So you saw me before removing the supraconstruction. The incision is super simple and easy once you remove the supraconstruction, sulcular, and then you find intact bone somewhere where you start raising your flap, and then you separate and you remove in one piece the lesion. Very easy and simple. And then we'll shift to what you already saw, the rotating brush, under saline irrigation. So this procedure takes you 25 minutes. I mean, it's quite simple. And what we then do, again, I will not put anything here. the suturing that Stefan taught me 20 years ago, right? And then I think that will also be a question is we immediately reseat the superconstruction once we're done. So we never put anything to sleep, right? And if you follow this case, I have this lady for a year or so, you can see the most important part, the resolution of the inflammation. You'll see a response also radiographically, and for sure you have exposed threads. Patient has no problem to manage these.
I
The
mean,
case,
Jan, could we
sorry,
also just one quick question to that
sure,
case? I mean, we know the data from perio, from vertical GTR, is that a filling material is also able to keep up the container, so enlarge the area of let's call it regeneration. Would that also be an option to use a bone substitute to sort of open the container for a larger regeneration? You get my point?
sure. And you know what, Stefan, if I save that question to the next case, I think because that's
Perfect.
my final couple of slides, and I think it'll speak to exactly what you say.
Okay.
It's keeping the tissues containing, and then also sort of say, at least in the hypothesis, to serve and help healing. But I would also argue that what you see here, the response on the radiograph, this is natural, these are natural tissues, right? Patient's own tissues. So from a biological point of view, this is very nice to look at, because you know what it is, right? If you follow the case that I'll show you here, where we have this clear aesthetic component, right? And I think the worst nightmare is the exposure, I'm sorry, of metal, where you could imagine that the neck appears the blue and the patient will be completely dissatisfied, will not accept the situation, right? So limiting recession comes into play. So I will put the graft in this case. And as you say, I would thereby probably also tent the tissues. But if you now look at the case and it heals very nice, right? We are getting what we want from a clinical point of view. We actually also have a reasonable aesthetic outcome. Patients at least satisfied. But now help me interpreting what you see on the radiograph. Because even 5 years down the road, I think you and I can still see the graft in place. So there's also, at least theoretically, the idea that putting the graft will prevent, so to say, native tissues to populate the area, right? And that may or may not play a role, right? But from a biological point, I like the first case more because here we put a graft, and whatever that means, I think it's hard to interpret, right?
Got it.
But I will go back and say that what you see down here to the right, the absence of deprobing, absence of inflammation, that's what's going to guarantee, if I take that strong word, that the implant will survive over time. And I think, Stefan, that's what I prepared for tonight, answering a couple of questions that you put to me, and I'll be happy to discuss.
Jan, that was amazing. I mean, you sort of you got me. If I have a case tomorrow, I will leave my bird to the side and just use the tie brush. You got me. And I'm also a little bit thinking twice about the bone replacement material. So thank you for that input. Obviously, also your scientific work is just amazing. So congratulations to that.
Thanks.
Jan, there are questions like coming in like shotguns. The first, I already handed one question over to you. There's another question from Pascal Valentini. Hi, Pascal. Great that you logged in. He wants to know, obviously, he's famous for sinus lifting procedure. So he wants to know, is there a difference in peri-implantitis between grafted bone and native bone? And if there is a difference, should we treat it the same?
Yeah, this is a difficult question. From a clinical data set, there is no difference. It's not at higher risk, the augmented site, and there is no image or no data showing that they would behave differently, progress faster. If I go to the preclinical world, the experimental research, the experimental peri-implantitis models, there is some data showing that the grafted sites will progress faster than the native, right? How this would now translate into should we treat them differently? I would say probably not, because I already advocated for a rather fast treatment cascade, right? I mean, you make your decisions fast. So if I make, difficult question, of course, but if I make a careful conclusion for this, for Dr. Valentini, I would say look at them the same way and then also treat them in the same way.
Good point. There's a question from Massimo, and I like this question very much. He says, if you look into that on a microscopic idea, there is no way that these type brushes are able to get into every valley of your moderate rough surface. So how can we really believe that it's going to clean everything? I think it's a valid point.
Very, very valid point. I of course agree. I mean, it's completely correct, has to be correct. We will not create a perfectly clean surface. I don't have any solution for that, but I will argue with perio because that will be the same, right? We will not create a sterile surface at the tooth either, and yet we are successful in managing periodontitis. So I think that would be my answer, that we won't have to be perfect. We just have to go below that individual threshold in
Yeah.
bacterial load that allows whatever we call a biosis and so on and so on, right? So I don't think we have to be. We
So
aim,
there's a critical amount for the body.
exactly. We obviously don't know where we are, so we're trying our best and we should improve. But I don't think that by itself is a concern because perio will be exactly the same.
Yeah, and there's a question. Obviously, we've seen Labrida brush. You obviously know about this. Do you see an indication for it? We obviously have not a bunch of literature on that. And the second question from Torkel, do you also use adjunctive antibiotics? I think you already alluded to that. I think you alluded to that with the non-surgical therapy. I think he's rather questioning it. Would you also apply it during surgery?
Yeah. Let me take that one first, Stefan.
Yeah.
And that's a little bit of a headache because there's been a shift rather recently to step away from the antibiotics.
Yeah.
While much of the literature, also the one I quoted, is based on the use of adjunctive antibiotics, right? So the study I cited by our own group had antibiotics as part of the surgical regimen, but the guidelines today are quite clear that we shouldn't. And our protocol is also no, right? We don't use antibiotics adjunct to surgery. There's one exception, that is if I go in again, I'm doing like a retreatment on a previous failure, I would probably consider to go with antibiotics. Then the question on Labrida, to me, is an instrument, an addition to the non-surgical part, right? It's plays for me no role in the surgical setting. And the studies that I'm aware of, they show modest or no benefit in the in scenarios where you have this mild incipient peri-implantitis, like a beginning, you have some shallow pockets. Maybe there you have a small chance, but in these established ones that I show you here, 8, 9, 10 millimeter deep pockets, it is probably not going to, so to say, move you over the edge, right? The issue that we have again is this kind of cost benefit, right?
Yeah.
You're asking the patient to pay, and then you need to show a clear benefit, and that data today is not really there.
Obviously, it could be with Labrida also a matter of remnants, I believe, also. Like,
Yeah, I mean, I have to say I'm not super firm, but here the concept is that actually these are anti-inflammatory components that if they stay, that's actually not the worst part because they will resolve and actually in a favorable way, right?
okay.
But that is probably I'm not the right guy to
Yeah.
go into detail on this.
Thanks. There's another question, and we have two questions from Mario and Iva Milinkovic is when to treat and when to remove.
Ah,
Yeah, we have
okay.
another hour of discussion. Give us your take. Is it still
Yeah.
50% of bone loss? Is that still the rule of thumb, or what should we do?
No, I mean, I would say no to that. I think you can still see my case, right? The
Yeah, yeah,
one, the
obviously.
upper molar. I think I can use this one to illustrate some thinking that we have. I would say that there's no way you can have a cookbook on 80%, 10 millimeter, this kind of, that's the threshold. I would argue that it has to come from a case-to-case, site-to-site discussion where you look into treatment planning. If you take this case and the tooth behind the affected implant, if that had been a third implant, I would not have hesitated for a second. I would never have treated. I would have redone the pros and that's it, right? Implant supported. But if you think of if we lose this number six, how are you going to solve it? You're going to start connecting tooth and implant, and open all of that can of worms. So I would go very far again to avoid that. So I'll treat the case like this, right? So I think the hard endpoint is mobility. I mean, if the implant is moving, then obviously it's out. But other than that, I don't see that I could give you any recommendation on that's it.
I sometimes have a little bit the last doubt when I also would treat this case. I sometimes have a little bit the doubt that after my surgery that there will be of obviously there will be bone remodeling, right? And I had some cases, I mean this one is splintered now, but I had some cases which lost the
Yeah,
osseointegration before they sort of before the inflammation was sort of residually treated. You get my point? Do you
sure.
also have this fear?
Yeah, of course. I mean, I have a lot of failures, to be completely honest. And I think my story here was that this takes us, I mean, it's a 30-minute, 45-minute session. The patient is really
Right.
gone within the hour. So in my head, if the patient comes in like this, I can tell them, we have a shot, and that is we go for surgery rather quick. We have to agree on we're taking a risk together. And that I think is fair because we have a reasonable chance to manage. The alternatives are so heavy,
Yeah, yeah,
a new.
absolutely.
So I think this taking this chance is fair.
Absolutely fair. Yeah, and there's another question, so many questions for you. From Daniele De Sanctis, we also know him. What about the type of bone? I think he's alluding a little bit to chisel type of bone defect or more horizontal bone
Okay.
defect.
Mhm.
Does this make a difference when it also comes to regenerative or resective therapy? So I think the question would be also, would you also sometimes consider resection of bone maybe in a sort of chisel type defect?
Yeah. There's been quite a lot of work in put into first and foremost classifying the defects, and I'm just going to shift, and then also in what kind of surgical approach should you choose? And I have to be honest that, and I think Stefan, of course, that we come from a history of doing quite a lot of pocket elimination,
Yeah.
cutting bony edges and so on and so on. Actually, I'm not doing that at all. So I would say a pretty hard no on that one from my side. The only question really is open flap or graft.
Mm.
Um, And the point is the healing that you see, the remodeling in these cases, such as these sharp edges, will happen, so to say,
Yeah.
naturally. And I don't want to sacrifice bone, right? Because I do see this healing that occurs. Now, does now the defect geometry matter to the healing? The data set that we have, surprisingly, says no. So whether I have an open defect, such as this, a more contained defect, will not indicate the type of healing that I have a year down the road. So actually, this doesn't come into any, so to say, play, any decision making. So if you look at this case,
Yeah.
you see the healing down the road. And if I then add also the radiographs, you see that these sharp edges, they will kind of disappear naturally.
Sure.
And in the deeper parts, I will get some recovery of the bony edges.
Got it. Jan, there's another question from another Swede, Frank Skiberg from Sweden. He wants to have your take on galvosurge.
Yeah.
Obvious question, I get.
I'm happy. Hey, Frank, let me start there. Um, yeah, obviously it's a lot of discussion.
Please answer it in English, yeah, my friend.
I will. No Swedish,
That
no
was a
German.
good joke.
I'll stick to English. No, actually, it's quite interesting because a lot of what we already said will apply. The data, to my knowledge, is that there's one control study out there right now showing no benefit over basic treatment, so to say, what I've just shown you. So that's one side. And on the other, you have, of course, the costs that are associated with the procedure, meaning that you end up in a net negative, and that's where the recommendation would have to be. Now, note, please, that the guidelines did not make a mention of the technique, electrolytic decontamination, because there was nothing at the time. And now the studies are coming, and the one that I'm aware of Alberto Monge, friend of mine, showing basically no critical or no benefit actually at 1 year. So I would hesitate as of now to, so to say, invest and use this and ask my patients to pay for it because the data is missing. So it's a little bit the same story as with the other questions. And in this case, it's a little bit sharper because obviously the costs are quite, so to say, steep.
Yeah, that was amazing. We are at the end of our time, and I have one last question. The last questions is always my questions, and you have to help me out a little bit because we're so much talking about residual rough surface. I hear Danny Boozer talking about the worst thing which can happen to you is you leave exposed surface when you place an implant. We know this data from Belgium showing us that an initial bone loss over the rough surface is exaggerating the risk for peri-implantitis. And now we intentionally do that. So help me out. Is that not a problem, or just are we also changing the microbiota? I mean, you get my point?
Yeah, I mean, obviously you are completely right? I mean, the Belgian data, for instance, and looking at the case that you see right here, I mean, this case, of course, would fit right in. And of course, the risk for, in this case, recurrence is high. I mean, let's be honest, I can show you a lot of nice cases, but we have a lot of recurrence if I go to 5 years down the road, right? But you know, Stefan, if I can take your question and if I may answer by a question on my own as an answer, you know, if now the rough, and now if I emphasize rough surface is a problem, you know, I think what the whole issue, what the question that comes up is why do we have these rough surfaces to start with? It raises an old question,
Obviously.
right? Do we need rough surfaces? And again, what's the benefit? Because the cost, that's what you and I are talking about, is there. The risk is there, right? So can we get away? Should we maybe turn back and go to surfaces that are easier to clean, maybe don't imply the risk that you and I are talking about? And I think, that's a personal opinion, of course, the industry is hearing this, at least, and this could be the future, I think, giving you and me the choice for a high-risk patient. You know, the guy that we know is at risk for issues, that we could choose the same implant, same system, with a surface of lesser complexity or whatever it is, in a way that you would choose a car in black or in red, depending on the case that you have in front of you. High risk versus maybe a low risk guy. So And that would take out the sting out of this discussion. Oh, wow, we have exposed surfaces and this and that, right? Because maybe we know that surface is going to be rather easy to manage if something goes wrong.
Very good point, Jan. I mean, I wouldn't go so far that to say that they are hearing us, but maybe they're at least hearing us in the shoulder part of the implant, right? We see a little bit the tendency of going back to hybrid type implants,
Exactly.
which is obviously, I mean, I'm working a lot with the perio patient is obviously a good thing. Jan, with that philosophical thinking, we are at the end of our lecture. There are still coming in questions coming in. Probably you'll see Jan all around the world, so approach him and just get to him and ask the question. If someone wants to come to Lisbon next year, I'm not sure if Jan comes. I guess you will. September in Lisbon, Jan, what could be nicer? The EAO annual congress is in Lisbon. There is a rate to register, so quite cheap. So use that to register for that congress. With this, Jan, I would again like to thank you. It was such a nice meeting. I could do that for another hour, 2 hours with you, but then it's probably Christmas if we finish. With this, I would like to thank everyone. Also, thank everyone for the attention this year to the Just Ask. Use the holidays to come back into your game. Look at some of the previous Just Ask. Some of them are really nice and we can learn a lot. With this, I would like to thank you, Jan, also on behalf of the EAO and the EAO board for making this possible. It was amazing. The people, they applaud you in the chat. You can look at this later. With this, good night. Thank you to all around the world, and in particular to Sweden. Ciao, my friend Jan. Ciao, ciao.
Thanks,
Everyone.
Stefan. Thanks,
Ciao.
everybody. Bye-bye.